Questions? Anybody? You have a question? Questions? Yes, hang on. Hold the mic close to your mouth.
Dr. Connolly, am I saying your name right? Okay. My question is, have you, since you talked in your lecture about how cancer cells are primarily anaerobic, have you heard of EWOT therapy? Exercise with oxygen therapy? I'd like to hear your thoughts on that.
Question. It's on. Just make sure it is. Just.
So she asked about if I'd ever heard of EWOT therapy. And actually, that's been around for a very long time. So it's exercise with oxygen therapy. It's absolutely amazing, not just for prevention of cancer, but with patients. So I do a blood test called the PHI. It's a fasting blood test, and it determines if the patient has hypoxia in their cell, low oxygen. So what I usually do in the practice, I get everyone exercising to get oxygen in. And then I will use a concentrated chlorophyll called chloroxygen. And then I have them do Wim Hof deep breathing exercises. And then I use hyperbaric, EWOT, nanobath, oxygen, and so all those different things. So I love EWOT therapy. It's a great way to super oxygenate the body. Even for, like, athletes use it for increasing their stamina and energy. So yes, it's a phenomenal tool.
I have a question for Dr. Connolly. In regards to her impressions or users of fenbendazole for tumor shrinkage and then be able to achieve a better results with their patients using that or not.
Right, so he's talking about fenbendazole, which is a really old parasitic drug. So there's a great book called Starving Cancer. And so we utilize in our practice about probably at least 15 different drugs. Fenbendazole is one of them. So dipyridamole is one of them, doxycycline, metformin. We use all of them. So what we do to decide is we bioenergy test to see what the patient's body wants, or we will also send it to the RGCC lab to see. So I have personally used starving cancer drugs for probably several years. Ivermectin, for example, blocks 8 pathways to cancer. So there's lots of great drugs that really, and fenbendazole is just one of many. It's not the slam dunk you think it is. There's no slam dunk I've seen in cancer where I've been like, oh my gosh, this is, this chemo or this drug or this. No, it's you must change the environmental terrain of every aspect of the patient. So fenbendazole is just one of the many hundred things that I would use.
Question?
Okay.
So I have a question. You mentioned that the methylation is acquired through life. Can you comment more about that and what people can do about it, please?
Right. So we have a biochemical process in our bodies called methylation. It's basically donating methyl group, CH3, to allow our DNA to be processed. So what happens is, as we matriculate through the journey of life, we have all these extraneous things that come into our life that change our genetics. And so there's a blood test called MTHFR, methylation tetrahydrofolate reductase, and I do it on every single patient because 50% of the population today has that defect. So if you have that defect, you're not processing your DNA properly, so you have to take methylated vitamins, specifically B folate, methyl B, and other. I use a combination. And you have to fix that or you're at risk at all diseases. And so people think you inherit from your parents. No, it's something you've acquired over the exposure of all the different things that you're influencing in your body every day, like everything, all the chemicals, toxins, everything that you're exposed to. They call it the exposome now. And then the imprintome is what you're imprinting every single day. So, but it's invaluable to the care of the patient because it's going to make or break a patient with cancer, heart disease, depression, I mean, every illness, because it's basic to DNA replication every day. So you like everyone, like it should be standard operating procedures in medicine that patients have that, because you're making or breaking that patient every day. Like, let's say you treat a patient with depression, well, instead of going to drugs, you would do that first, because just correcting and giving them methylated B vitamins can dramatically direct that patient's outcome. So it's like the tragedy what's going on in medicine. So
Thank you.
Dr. Keneally, I like to add to that too, with methylation pathways, detox and antioxidant pathways. I mentioned in my lecture that the use of selenium is often overlooked or feared in some cases. You know, if we're working with things like glutathione, we realize in the absence of selenium, you don't get the glutathione peroxidase form, right? So we can focus so much and miss some of these key minerals in terms of methylation pathways. So absolutely critical to have that comprehensive view. More questions?
Dr. Gosweller, how is your this new knowledge changed how you treat periodontal disease?
I think from the start, it's changed my conversation with the patient. When we sit down with the patient, I mean, I interview everyone before they come into my office for treatment. And if they're a perio patient, the conversation, because so many times by the time they get to me, they're frustrated because they say, well, you know, I've done all this, I've had the scalene root planing, I've gone through all this, and the problem still seems to persist. So I start this conversation with them about, well, this is an autoimmune problem, and that, so we're treating this in partnership with our functional medicine naturopaths that we work with. And so I think that provides the patients then with some hope. I mean, a lot of times they're just really down and frustrated with this. So I think that's probably the first thing. Treatment-wise, you know, it's interesting to listen to the other speakers, because just about everybody up here, I think, kind of figures into how I look at these patients. I mean, if they have like sleeping deficits, I mean, that's huge, because it affects the way they oxygenate for a significant portion of their life. So, yeah, all of these various portions fit in with perio, because perio is a huge dysregulation, and it's just a matter of then identifying all the various dysregulations that you have to start to try to correct. Now, I'm not going to spend all the time trying to do that, but certainly I try to make the patient aware of what's going on, and then that hopefully makes it that much easier for my functional medicine or naturopath partner then to treat the patient effectively. So, okay.
First of all, thank you all for being here to lecture for us. It's been an amazing seminar so far, and I've enjoyed hearing you speak. My question is directed for Dr. Connolly. I was wondering, two questions actually. What biomeridian survey system are you using? And when you present a biomeridian survey or a discussion on electrosmog affecting people's health, how do you present that to your patients?
Okay, so we are using, I've had like 3 different devices so far. And so the original person who I had working in my office is in Sarasota, Florida. And then I would have her fly out to my office every month to see my patients because she was so good at that. And then I finally found somebody who taught her, and then I sent the girl that I had her actually be taught by like 12 other people because you learn pearls from every person. And so, as I told you in the lecture, the original guy who developed this was Reinhold Voll. If you don't know him, you should look him up. And everyone here in this room should have somebody do it in their office or something because it's an invaluable tool. So Reinhold Voll, as I said, was a physician and physicist, and he was the one that originally taught the acupuncture points by hand. The books were literally 1,000 pages. I had an acupuncture that worked for me years ago, and he was trained by him. And so that was all computerized to the devices we have today. And I have to say, I get new information on devices all the time. But I have, like another guy was just telling me he has enough toys. I have enough toys. And so what we're using is working. So the way I describe it to patients is that we are bioenergetic beings. So our heart is an electrical energy output. And when you get an EKG, that is an electrical energy output. When you do an EEG, it's an electrical energy output. You're measuring it. In fact, the definition of death, there is no, brain waves, right? So you have acupuncture points all over your body. And so we take the top 50 acupuncture points and we measure the point, and we take the point. And so I tell people it's like a string of pearls to an organ or gland to the body. And so we'll know if the energy is flowing through, then we know that energy point is healthy. Now, if it's not, because it shows up on the screen, it'll show up like green is like, at a level of 50, so a give or take a few points, that's going to be okay. But if it's resonating low, then we know that there is a blockage. And then you start testing everything that could possibly open up that meridian, and then you'll see that, it dramatically improves. So that's how I describe it to patients. And, most patients, like you are probably aware of, they don't know this because this is not part of conventional medicine. It should be, because it would save, it's very economical to do, and you get lots of information. Because like I said, when you look at someone physically, you can diagnose and look at lots of things with a patient. And then when you do your blood work, you're capturing a minute of time. Think about it, 1 minute of time of a person's day. So if you send a person's cholesterol level to 20 labs, how many different results do you think you're going to get? 21, he said. Yeah, that's exactly correct, okay? And so, we have to have other tools. Yes, you can do total body scans, but everything's about energy. Albert Einstein said, everything is about energy. And now that we know that every cell in our body emanates photons of energy, we know that we're energy, and energy precedes action. So we have to make this a better tool and utilizable tool in our practices. Whether you're a dentist, naturopath, or MD, it doesn't matter. These are, invaluable ways to help you fix the patient. Because blood testing can't tell you everything. I know I do an enormous amount of blood testing, but when I do bioenergetic testing, which probably would be my go-to first thing, after I saw the patient, got their input, that still doesn't matter with the bioenergetic testing. You're still going to find things that you can't find in conventional workup of testing.
Thank you. Wait. Don't ask questions about the microphone.
What'd you say? It's called EDS 2000. If you email me, I'll be glad to send you information. Okay? And I have a podcast. I do have a podcast that we specifically talk about that. So, listen to the podcast specifically on that.
Other questions? Got a question?
Ben, I can't pronounce your last name, so I'm just going to call you Ben because I'll screw it up. So on your presentation, I really enjoyed it, and one of the things that I feel might be helpful for everybody in the room is you've been doing this for a long time, and the longer you do something, you pick up what's called pattern recognition. You start seeing patterns. Maybe you could share with the Academy, like, the people that you're helping, there are certain patterns that they're responding to. And I'm talking about behavioral patterns. There are certain times you meet with patients and you can talk to them till the cows are coming home, but you just know that deep down inside, even though you know what you know is truth, it's a principle, they're just not gonna. So I just thought it'd be valuable for you to share with everybody, like, what are some of the patterns you see on those that are accepting what you're presenting and they're getting healthy?
Yeah, thank you very much. I was spending my time figuring out why I'm sitting in this panel of people. I should be getting them water and stuff. What a group to be with. Thank you very much for having me here. I really appreciate it. The question about patterns with the parents, I have a little technique that has worked with, the parents over the years, and so I will only have a consultation with both parents present. I can't talk to one or the other because that never works out when one hears. I spend at least an hour, it could be an hour and a half, discussing the records and the workup that we did for the child. So when I collect all that data, I need both parents present, no children present. So that's how I kind of start the pathway of educating. So I need an amount of time to educate the parents. So what I do know is that the parents come in and are living the struggle with the symptoms, because every one of the symptoms is real. And so some of these kids have one symptom and some of them have all of the symptoms, and then most are in the middle with a mixture of symptoms. So the parents are definitely struggling with a list of symptoms. What they don't know is the connection to the jaw growth and development. And so I have to take them from they totally understand the symptoms that they're struggling with to the end result has to be that they totally understand that what I have to offer will make a difference in that symptom list. And that takes me about an hour to an hour and a half with 2 parents present and no children present, no distractions. And then we sit down in a closed room and I basically go through the diagnostic information I took for their child, which includes a lot of questionnaires. We have a lot of sheets of paper that have all kinds of questions that are outside of dentistry that we would be asking, like bedwetting and ear infections and the list of things that are symptoms that are related to breathing, sleeping, that just aren't in a normal dental thing. Then there's a list of habits and things that the kids might be doing at home or school that we'd like to learn about. And then we ask the parents to observe their child and send that back to us. So we don't ask for any forms to be filled out on the spot. No parent is going to give you good information in 5 minutes when all their focus is on how quickly can the kid's teeth be cleaned? I got to get to the laundry, the dry cleaning, drop off the kid at the store and get home, and the other one's got to go to soccer practice. So nobody's paying attention at the time. So it's common for them to write down no and draw a line down the page. They don't have any problems, just clean the teeth. So we have someone who instructs them on how to fill out these forms, what we're looking for, what we're observing, and then they come back and we sit down and we spend an hour to an hour and a half. Now, 18 years in, I've gotten a lot better at that, and so over time, you start recognizing there are groups of people. Most of them are very receptive to hearing the information because they totally understand the sequence of events, from the lack of jaw growth and development to the struggle to breathe well, interfering with sleep, producing symptoms. So they totally get the sequence of events, and when you walk them down the kind of credentials their child has versus where a normally or ideally growing child would be, the end result is you need a parent to tell you how, or say at the end of this, how soon do we start? Because in my world, I only believe that I can help that child and I need to treat that child, or somebody like-minded needs to treat that child. Because in the back of my head, I know what happens to that child if they go down the road to that office or that office or that office. Mm-hmm. That child will come back missing teeth, having all kinds of the wrong direction going on. So I guess the pattern is spending the time with both parents to educate them so that they understand. I feel like I make it very difficult for a parent to say, no, we don't need that or we don't want that. I've gotten really good at that. It takes some time. I want to think that I've perfected it, but you can always learn more and do more. I try to teach other doctors to do this, and part of it is the consultation process. Like, how do you walk a parent through this so you can connect A to Z and make sure they understand what you have to offer their child? I hope that was a good enough answer for you.
Thank you. Questions? Yep.
So it's a question for Dr. Ben Miraglia. So I remember being taught in ortho that especially for guys, it is anticipated that the mandible can continue developing into late teens and early 20s. And so a lot of times when ortho is done in teenage years, it becomes edge to edge or slight class 3. Now I wonder, with a lot of times it being maxillary actually deficiency, do you see that happening with children that over?
Yeah, I can explain that actually. What you brought up was the later mandibular growth. In general, you're talking about later mandibular growth. And so what the ortho community has recognized is that a lot of their patients end up either edge-to-edge bite or class 3 looking anterior crossbite. And it's not necessarily later mandibular growth. So I have a different perspective. It's early maxillary deficiency. Yeah. Now what happens in the ortho community is that the people who have an edge-to-edge or a class 3 type of bite that came later, they had a set of braces as a young age. Now, braces are a restrictor. So they lock the maxilla and they line up the teeth, but the maxilla cannot grow forward with a set of braces on it. So what you get from a set of braces is maxillary restriction. And if you don't attend to the tongue and deliver it to the roof of the mouth, the maxilla will not be growing, and you facilitated it being locked in place by a set of braces for 2 years, but the mandible will have the action of the tongue being low to continue to grow normally. So it's not late mandibular growth, it's early maxillary deficiency or early maxillary restriction. It doesn't happen to the patients we treat. Yeah.
Anybody else?
This is for Dr. Moralia also. In your course, you said you're wanting ideally 50 millimeters on airway in between molars. Where are you measuring that from?
So yes, you're referencing the transverse measurement.
Yeah.
So it's my favorite diagnostic tool. If you said you were going to strip all of the diagnostic tools away from me, but I could only keep one, I would tell you all I need is the transverse measurement. That would be the one that I would keep. So the transverse measurement is the distance between 3 and 14, the upper first molars, and you measure it right at the gum line. It's the shortest distance you can measure between those two teeth at the gum line.
You go in lingual or buccal? Gum line? Lingual?
Lingual,
Okay,
in between.
Really? So
in
you're
between.
wanting 50 there. Okay.
It's an in-between measurement. So in between 3 and 14, you would like to have a transverse measurement recorded.
Okay.
Now, let's go to the primary teeth because that's A and J. In the primary teeth, if we're lettering from A to T, we would have A and J. We'd be measuring those. So to give you a frame of reference for what would be the minimum number that a child would achieve to be considered, at the minimum, normal or ideal growth. 4 years old, A and J should be 30 millimeters apart. By age 8, 35. By age 12, 40. By age 18, 45. That's a minimum. And the reason those minimums exist is because it's that set of numbers that delivers half of the wisdom teeth erupting into function. If you would like to see closer to 90 or 100% of the wisdom teeth erupting into function, those numbers have to gain by 5. So you'd start at 35, 40, 45, 50. So when you look at anthropology research, cultures prior to industrial Western living, they measure 50, 55 millimeters between 3 and 14. But they have 100% eruption of wisdom teeth. There's a full body of teeth in there because you have a jaw that is normally or fully grown. So what we look at today are children who are miniatures. You know, the adults come in the 20s. And you're going to have it in it's not just in New York, by the way. These numbers don't exist in New York. They're all over. So wherever you're from, you're going to find a very narrow transverse measurement.
Okay, real quick repeat. I got every age except your last one, which was 45 by what age?
18.
18, thanks.
And if you hit those targets, 30, 35, 40, 45, you would have about a 50% eruption of your wisdom teeth. So in my world, that's still deficient. So you start to go above those numbers by those ages to guide the growth and development, and with the breathing and the musculature following suit, the higher you can go above those numbers, the more you will see your wisdom teeth erupt into function.
Sorry. So in adults, what are you doing when they have a intramolar width, and obviously they can't have wisdom teeth erupting, right? So I'm already talking to them about, okay, we have two options. I don't really like extracting wisdom teeth because you're already airway, and now I'm going to have that suffer more. But are you able to expand those adults? So I do have some 28, 29 millimeters, right, in
25,
the office.
they walk into 25, some of them.
And so what are you doing? Are you actually able to get wisdom teeth to fully erupt in the adult dentition? When it's fully formed, say you've got a 50-year-old.
Yeah, 50 years old, it's not likely I'm going to get the wisdom tooth to erupt if it's embedded or impacted. But I won't take it out. It doesn't mean I'm extracting those teeth.
It's in, but it's impacted soft tissue-wise and maybe a little bony on the distal. Let's say
If it's soft tissue only, I would consider the laser removal of the soft tissue only. But after expansive techniques. In other words, grow the arch first, then go ahead and...
That's what I mean. Can you grow the arch enough that you can make the space in an adult fixed dentition?
I'm wondering if you have a specific patient you have in mind.
I have many patients.
Are we treating your husband right now in this meeting right here?
No, I have many patients that have similar presentations.
Yes.
And so I'm just curious because...
So it's not a goal of mine in an adult that you're describing to get the wisdom tooth in. It becomes, it's not even a goal on a list.
So I don't necessarily.
But I'm looking to grow the anatomy, yes.
Okay.
So in an adult looking to grow the anatomy.
And you feel like you can grow large enough to a 50, 55 that ultimately the wisdom tooth could?
No, very difficult to do that. So yeah, when an adult comes in at 25, we're not even getting to 40. But the idea is any amount that you can increase them will give the tongue more space. And then you're doing a list of things because there's the nasal attention, there's the frenum releases as indicated, there's myofunctional therapy. You're still going to try to grow that tongue as big a chamber as you can. You're still going to have an effect on the nasal cavity as well. And then with all of those things, how much did you deliver? What was the level of improvement? Now I can tell you in the severe obstructive sleep apnea category, I've had 3 patients choose the MMA surgery, but that's always in the middle of orthopedic and orthodontic care. So it's grow the width, have the surgery, then coordinate the teeth. So it really is 3 parts to that. But if you wanted a cure from OSA in the severe category, you probably have to think about an MMA as an option. Surgical procedures do exist. I tend to use them the least amount. But when the adult comes in and has the list of symptoms, we're trying to develop the arches as much as we can, but I can't get 25 to 40 with removable, with non-surgical types of techniques.
Are you doing bicortical expansions treatments on your adult patients?
No.
Okay. Okay.
Those are helpful. Not that I don't mind those.
Any questions besides Candace? Totally kidding.
To the Candace show.
Yeah, I have a question for Dr. Carstensen. What's that? So my question is regarding the mandibular advancement devices. Do you notice bite changes with these devices? And then if you do, how do you approach it?
So, yes, I do. We have a very adaptable body system, including our temporomandibular joint complex. So if we hold the jaw forward for 7, 8 hours over a long period of time, it's kind of unrealistic to think that that joint won't try to adapt to that. That being said, what we do is we try and get every one of our patients to reset that alignment every morning with some physical therapy that they do in conjunction with using their mandibular advancement devices. I'm a Pankey-trained restorative dentist, did that for a long time. I like a fine occlusion, but I like a big open airway better, and so I don't obsess about the teeth coming back together. We don't get tooth movement very much anymore. We used to get more tooth movement with the appliances that were early in days. Nowadays, the appliances fit so well that the teeth stay in one place, but the jaw can move. So the alignment of the mandible can change. But we assess that when that comes in, and we talk to our patients about the troubles they're having, and we balance a medical effect. One of the things I like to say to my patients is once you've been diagnosed with a breathing disorder, nothing's free after that. Because if you don't treat it, you've got medical problems, and all of our treatments have side effects. So we have to pick which ones we're willing to live with.
So do you ever consider ortho to realign teeth?
I always consider that, yeah. That's part of my workup for every patient.
Like after the fact?
Or before, yeah. That's one of the choices they have on the table when they come through my office. And so if they come back with a change in their jaw position, jaw alignment, they can always go and choose that. We have, down the street, I have an orthodontist that's spectacular at those kind of things. So I'm fortunate in my community. I don't see the cases like Ben showed this morning with the before and after combination problems.
Thank you.
I'm lucky.
I have another question for Dr. Moralia. So my question is about the appliances you're using. So for one of your cases for class 2, I know you mentioned that you do the upper and the lower appliances. So do you use them the same time, or you expand the upper and then you move to the lower?
Yeah, so nice question about the types of expanders that I use. So I use generic fixed expanders. You know, the upper one that I showed a single picture of today it's called the super screw expander. And it has a cylinder that's hexagonal, and it comes with a wrench. It's very easy for parents to turn, so I like that one because it's kind of sleek and aerodynamic. It has one bar across the center and a little wrench to turn. So typically the technique involves 2 expanders, upper and lower, because no child needs 4 millimeters of expansion. And if you use an upper expander only, it's equivalent to having no expander. So an upper alone will give you about 3 to 4 millimeters, and then when you take it away, they'll go right back to match the lower teeth. You can't go past the lower teeth. So it makes no sense to use one. So we use both because anytime you're going to put an expander in a child, I have not met a child in 18 years that needs less than 8. So you're beginning at 8, and the kids who need 16 and 20 go through 2 or 3 rounds of expanders. So it could be 2 sets, 3 sets, 4 sets, whatever it takes to get them to 40. The idea there is the upper goes in first. My preference or technique is that I place the upper first because the upper sets the tone for where the lower can go. So the way I see it is that the maxilla is the criminal and the mandible's the victim. So the mandible can only land where the maxilla gives it permission to. And so you want to develop the maxilla and put it where it belongs and then have the mandible follow it. It doesn't mean I do the entire upper expansion first, because if I did 8 or 12 or 16 millimeters of upper expansion, the top teeth would be outside of the lower teeth. So we're not doing that. But what I like to do is get the upper going so that we lead the way with the upper expander. By 3 to 4 millimeters of expansion, the lower goes in. And the lower, I use a simple lower Schwartz fixed expander. And that has the little pin that you roll the wheel on, and twice a week is a turn pattern. But with those 2 in there, as soon as the lower goes in, the upper turning pattern drops to match the lower. It's so that the upper has a lead on the lower but will never go beyond. And a lower expansion appliance in a child can be turned like twice a week. So whatever your turning pattern was for the upper would be more aggressive early on, could be every day, you could turn it once a day kind of thing. You would back down to twice a week to match the lower. Now you have the upper has a lead and then the lower can follow it. Eventually you'll pause on the upper and let the lower fully catch up to it, and then you'll figure out when the expander gets to either 8 millimeters or 40 millimeters, whichever is the goal. Do you need more? Do you have to go more? Where is the child? How are the symptoms, etc.? And you figure out some children need to go to 45. Some kids are good at 38, but the idea is you're going to need at least an 8 millimeter advancement of the maxillary arch. You're going to need the lower to follow it. So a pair of expanders. The first one is the top. I like to get a lead, and then the lower one follows.
Okay. And then do you use a 3-way for the upper? Because I know you mentioned when you do the expansion transverse, then
Yeah,
the maxilla will move forward. But do you
Right.
ever use the 3-way, AP
Very
and
rarely.
transverse?
Very rarely. So in a child, almost never. But in an adult, that can happen. So if you're thinking about the class 3 type of patient, in a child, I would start with the transverse only. The lateral expansion delivers forward movement. So the maxilla, turns out, it's backed up from behind mostly. So when you push laterally, the body pushes forward. So you get basically an A-point movement forward from lateral expansion. That research was Dr. McNamara's out of the University of Michigan. So just lateral expansion alone will deliver the maxilla coming forward for you. So I'd like to see how much we get out of that. All the class 1s and 2s, that's fine for. So the only time I would think about a 3-way would be, okay, if it's going to be a class 3 patient. But in a child, I'd go for the width first. Because when you look at a child who we would call class 3, I don't use class 3 anymore. I call it severe maxillary deficiency. And the first thing to do is get that child to 40. And usually they're crossbite, either one or both sides. The maxilla is very tiny. So they might go through 2 rounds of upper expansion to 1 lower, and all of a sudden they're not class 3. So the goal would be the width first. You can, in a child, incorporate reverse pull headgear. You can get some reverse pull headgear going. But even then, if you want to stay, let's say, fully forward, you would have that made to go from your forehead to your chest plate, not from your forehead to your chin. Because a reverse pull headgear that supports on the chin is driving the lower back. That is not a full protractive treatment. That is a lower retractive technique. So I would prefer to go forehead to chest plate with a reverse pull headgear. If you're going to use that, you may as well do it right. So most of the time, it's just lateral expansion. Yeah.
Any more questions? No. Anybody else? All right, here we go.
Dr. Baralia.
Yes, hello.
Hi. So when do you choose or decide to use a removable expander for an adult on the lower versus just an upper removable with lower aligners?
So it turns out with the lower arch, most of the time, the posterior teeth have such excess lingual inclination that clear aligners alone can upright and deliver the space that you need for the tongue. So most adults we treat with upper removable expansion appliances to grow the maxilla and lower clear aligners to upright all the back teeth to follow along. Rarely do I need a lower removable expansion appliance, in which case it would be a lower removable Schwartz style to end up growing the lower jaw. I would tell you it's more likely if the patient comes in 4 bi-extracted and 4 wisdom teeth extracted. Because if you have 24 teeth, chances are they're really tiny. Then we would be thinking about we probably need both maybe to get enough room to make a difference in whatever the symptom list might be. But in 28 or more teeth, you probably have lingual inclination you can control with clear aligners alone.
Another question, how much have you gotten with a removable expander on the upper? What's the range that you usually get with an adult?
The removable expansion appliances max out at about 7 millimeters. So I have gotten to 7, and when you get to 7, you make another one if you want more. So if it maxes out at 7 and you want more, you make another one. Just take a new scan, send it to the lab, make another one, and go another round. So
last
7.
question, I'm sorry.
Yep.
So if you get 7 or if you need a second upper removable, you know, there's only so much that clear aligner can upright without the upper going past it. So is that when you would consider a lower removable?
You could. If you have like a patient who measures 25 at the beginning, you might be doing a couple of rounds of removable appliances first, then switching to aligners. If they're around 30 or more, usually upper alone is fine. But again, if you feel like I want to keep going on the top, let me make a lower. It's never a mistake to make a lower Schwartz removable appliance because it's uprighting the posterior teeth. And more interesting is that you can get the symphysis to split and the lower incisors. You can grow the middle of that mandible almost at any age. So we see the lower incisors separate and kind of migrate across. So you can have mandibular growth just the same way in a child and an adult. It's just slower.
Mm-hmm.
Yeah.
Thank you.
I've made some reservations, Ben, for dinner for you and these 3 ladies.
Yeah.
We can finish the discussion then.
Terrific.
Anybody else? Questions for anybody but Ben?
Get restraining orders made up.
So in the post-COVID world, there's a belief that chronic problems are going to be epidemic. And we have a great bunch of speakers here, and people in this room are going to be part of the answers to solving this problem. I would like to hear from each one of you what your prediction of what's going to happen and how what you are doing will make a difference in the world that we're going to see in the future.
Each one of you, so except for Ben. Let's get.
No. Well, I have an easy part of that because I talked about the importance of nasal breathing and getting a proper CO2 oxygen balance, making sure nitric oxide is injected into every breath coming in, and it supports the balance between the parasympathetic and sympathetic nervous system if you breathe properly through your nose. And those are setting up fundamentals for your body to be able to resist some of the challenges that are coming forward. So proper nose breathing in a slow and deep way, that's the way it's going to be.
And I have the second easiest answer in there because most of what I treat are the children. I do see teens and adults, but in the younger group, the key for me is growing the maxilla. So I refer to the maxilla as that is your bone of life and bone of health. As your maxilla goes, the human goes. So if you're going to start out on the right foot, what you need is a fully grown maxilla. So in my world, the answer would be make sure that the human being you're treating has a fully grown maxilla, and a lot of other things will fall in place, which the rest of this group is going to help me with afterwards.
Well, I think it's going to depend upon those that succumb to the pressure of the mRNA and those of us that didn't. Those of us that didn't will survive normally. I mean, we've been exposed to viruses for as long as mankind's been around. Those that get the mRNA injection are going to have a problem that we don't know the future of because there's no off switch for making that spike protein. What we're learning is that you can kind of mitigate the inflammatory response to that spike protein and prevent the microemboli and the D-dimer upregulation. But I think it's an experiment that's going to go horribly wrong, and I don't know what the mitigation for those patients is going to be. But for the rest of us, I don't think there's any problem whatsoever.
Yeah, I would agree with that. I think, I've put the concept into X-Men type discussion. Wolverine, you guys know the Wolverine regenerates faster than he degenerates. So the key moving forward is how do we facilitate that normal process of regeneration that happens tremendously in children and babies to carry it through our lifespan or health span if we expand that. And that's why, as a homeopath, I focal point on, obviously what is showing in a patient, but what are we doing to accelerate recovery in a balanced way, in a symphonic, beautiful way, so we don't have aberrant growth. And we've seen in the COVID crazy 2 years, the manifestation of hidden chronicities in people come manifest right out for everybody to see. And we've also seen some interesting things about what you thought people believed about experimental injections and what I actually believed when they were frightened, right? How many of us would reconnect to the source of all wisdom, which goes far beyond any of our training, right to the heart of God, our Creator. And getting that guidance is important. And restoring our ability to eat food as our ancestors did. We talk about it, but we don't do it because we don't have to. And now we're talking about such severe supply chain disruptions coming up and other things that we now are coming to the point where we have to. And if you have to grow food, it's too late to start growing food. So this is why I say we must look beyond even our training to go into things our ancestors did, whether they have a degree or not. So that's where we are moving forward.
I totally agree with everybody who spoke before me. I think the future of the healthy mankind rests with sleep, oxygenation, and all of that is driven by a fully developed maxilla. I'm in total agreement with Ben here. And I think mRNA aside, there will be two classes of patients. The one that are fit to become well, subject to a fully developed maxilla, and secondly, subject to immune competence, which depends on sleep and a wide open airway, which again comes back to a maxilla developed to its fullest extent.
So, it's a really loaded question. And I think we can't, number one, judge anyone's pathway. As practitioners, we're here to be compassionate and caring and serving and unconditional in our delivery and taking care of patients, no matter how. And unfortunately, we are in a very serious sick care system, even that started before COVID. And I've been doing this 35 years, and my husband and I have 7 kids and now almost 3 grandkids. So I was always a very, ranter and raver about health with my kids. And because it starts with really, before you even think about having kids, it's like, okay, you need 2 healthy adults, because look at autism. Autism is 1 in 37 people. And so we have to really start the family before it starts with the proper intention and with the right parents who are leading very committed, dedicated, healthy lifestyles. It's really the bottom line. And then, we all have to do our part in educating and empowering and supporting people in choosing a life of health as opposed to a life of sickness. And, unfortunately, our system is it's really, really, really terrible about, You go to the doctor and you get a drug or you get a procedure. It's really, that's all that's available to patients, and that's not what the answer is. And Robert talked about we have to eat like our ancestors. We have hundreds of thousands of years of anthropological studies of like how we eat. Now we're going to change it in the last 50 years when we have all this information. And so, and you know, the vaccine is just another detour, just like I've experienced personally myself with DES. And I had to overcome a lot of things, but luckily I had the fortune of knowing what to do in my own personal situation, because that drug is never used. It's not, I mean, for you people out there, my mother took a drug when she was pregnant with me that altered the course of my health journey on many, many different pathways. And so, you know, luckily I grew up in Texas, and my mother, you know, raised us on sauerkraut and liver and, you know, pate and grass-fed beef and all that. So I grew up like that. But the bottom line, no matter who walks in your room and no matter what, you've got to meet a person with love and service, period.
Well, as a general dentist, I consider myself to be more frontline. I see my patients regularly. I know them very well, and I'm also very well connected into the community of the naturopaths, the functional chiropractors, those types. So I try to get them out of the medical system and into a naturopath and into a more healthy lifestyle. Most of them are already there just because of the practice that I have, but I know where to send them by personalities and what their certain issue is going on. So I feel like I'm a really good referral source because crowns and fillings aren't going to fix it.
I think we're going to need to think about the huge regret that's going to come from individuals who have been damaged by the vaccine, and we're going to need to have understanding for their situation. And as Dr. Connolly was mentioning, we're going to need to have understanding for that and try to help them as much as we can to get past this and to do what we can to facilitate that, because I'm seeing that already of people coming in who are suffering effects from this, who are trying to get out of it. And so I think that's going to be our challenge.
Okay, that's all the time we have. Let's give them a nice round of applause.